So to celebrate North East Health's Research Week in collaboration with the University of Melbourne, it's my great pleasure this afternoon to introduce Associate Professor Stephanie Best. Stephanie is a health services researcher working in implementation science. She has an extensive international clinical and healthcare management background as a chartered physiotherapist. She has more than a decade of research experience in implementation, working with a wide range of health and social care practitioners and other stakeholders. Currently, Stephanie is the Senior Research Lead, Implementation Science at the Peter MacCallum Cancer Centre, the Victorian Comprehensive Cancer Centre, and Australian Genomics. Associate Professor Best has a track record of designing and delivering national and statewide projects and experience working and researching in rural communities in Wales in the UK. Would you please welcome Associate Professor Stephanie Best?
Thank you very much, RHAN, for that warm welcome. It's an absolute pleasure to be with you this afternoon. So when RHAN sort of asked me if I'd be happy to give this keynote, I of course said absolutely, more than delighted to. But I've got quite a strong rural background. I've been living in Australia for about the last 5 years in a very, very metro area now. But for the 20 odd years before that, I was living in South Wales in the UK. And when I started pulling these slides together, we were midwinter here in Australia, here in Victoria. So I thought it would be only fair to give you an image of what winter used to look like for me when I was living back in South Wales. And this is a picture here of the Sugarloaf Mountain, which is just around the back from where I was living in Abergavenny. So I not only was practicing clinically in a rural community and rural setting, but I also did my PhD and some of my early research set in rural environments. So over 10 years ago now it was that I was working with the Welsh Government on some work that they did around rural health and running a series of rural health local innovation projects and sort of evaluating those and seeing how those went. So yeah, so the idea of talking with a rural health group was absolutely delightful for me. So enough about me. Let me crack on and see if we can get into the meat of what we're here to talk about today, which is around implementation science. So really going to see if I can just give you sort of a bit of an introduction to it. It's obviously only going to be sort of like, scratching the surface, but maybe it'll spark some interesting conversations and we can see where we go to from there. So the overview of today's session is really starting off thinking about the why and when you might want to think about using implementation science, what kind of lens you might want to be thinking about with implementation science. I've got one slide in here today that talks about outcomes that I think is a really, really useful slide when you're trying to start initiating some implementation research. And I've also got some slides in around the steps that you might want to think about when thinking of using implementation research. So I suppose the first question we always have to ask ourselves is why are we going to bother doing something? Do we actually need to be doing anything different, anything extra? Why do we need to have this implementation science? I've been implementing stuff for years. Thank you very much. Well, the reason is, well, there's plenty of reasons, but these are some of the ones that I've got here for you, is that long lead up time between the initiation of evidence that we could be using in practice to actually seeing it in practice at the bedside in routine clinical practice is often estimated to be 17 years. I mean, it's fairly sort of, plus and minus that kind of time. The main thing to get from that is actually it's just the length of time that if an evidence-based practice makes it into routine practice at all, it's an awfully long time. And so, as RHAN was saying, a lot of my work has been in the field of genomics, and that is a very fast moving field. And patients don't have that 17 years to wait for that evidence to catch up and get in for them to feel the benefit from it. The second area is around research waste. The longer we are not implementing that evidence that we could be using, we are wasting that funding that is going into generating that evidence to then not use it. So if we're generating evidence-based practice and not actually applying it, the funding that's being wasted is phenomenal. Let's see if I've put, yes, I have put the figure up here. So this is an estimate by a group called Shank in the United States. And they estimated that research waste comes to about $760 billion to over $900 billion. Now, totally get that the American and the Australian healthcare system are really quite different, different priorities, different ways of working, et cetera, et cetera. But even if we were to extrapolate a little bit of this into the Australian healthcare system, we're still talking millions and millions of dollars that's been wasted by not actually applying research into practice. But the final point that I've got on this slide here is around this idea of low value care. And so while we're not delivering the evidence that we have got generated, then that means that our patients are receiving low value care. Now, that's not to say that every practice is low value care at all. That's not what I'm trying to say. And we will get these pockets of excellence. But what we want these pockets of excellence to be spread far wider. So that's nice for the patients who are visiting clinicians who are in that pocket of excellence, but actually we want to see it much more equitable across the piece. So all these three factors that come together clearly lead to the potential for inequity in care, and not just poorer health outcomes, but also that patient experience that we want to be considering as well. My sort of short take-home message from this long slide that I've just talked about here is really, I'm saying that we can't afford to ignore implementation. Many of us are going to be familiar with this research translation continuum, and you can see that we go from the basic research at one point through translation to humans, translation to patients, into practice, and then into communities. These initials, the initial part of this continuum is focused very much on preclinical trials and clinical efficacy. And then we start talking much more about clinical effectiveness and implementation. And I've very actively overlapped those brackets that I've got there. I haven't just done you a messy slide here, because we can start to see some overlap of some of that work in this particular area. We tend to, as a healthcare community and practitioners and as funders, focus very much on these early stages here. And we kind of think that once we've got something translated to patients, our work here is done and we can relax. But of course, that is really just the beginning of the complex journey, isn't it? Because we need to be focusing on how do we get something into routine clinical practice and experienced far more widely. The key message in each of these stages, whether it's at T0 or T1, and we're looking at first in human trials, is we're trying to identify what are the active ingredients for success. What is it that's making the drug we might be trying, or a new approach to administering a medication? What is it that makes this approach successful? What are the active ingredients? Is there a particular population we should be looking at? Is there a frequency with which we should be administering whatever it might be? Exactly the same thing is going to happen when we come to this far end and we start talking about translation into practice and translation to communities. What are the active ingredients for success? Why will something work in one scenario and not necessarily in another scenario? Do we need to adapt the practice that we've got for it to be successful in various different settings? Now, clearly, there is no magic bullet when we're talking about any of these stages of the research continuum. And so we need to be sort of mindful of that and expect whichever sort of research it is that we're going to be doing to be taking some time. So you might be saying to yourself, implementation or implementation science. And as I say, I've got a long track record of working in clinical practice. So I've implemented a lot of stuff. And I'm sure many of the people who are here today have done the same sort of thing. I think one of the nice ways or I find this a helpful way to be thinking about implementation or implementation science is we can have at one end of this chalkboard here, we've got the development of the evidence-based practice. Then a miracle occurs and we get the evidence-based practice into routine care. And that's fabulous, but we don't necessarily know what that miracle is. We don't know what those active ingredients are that are happening in that step two. And this is where implementation science is really interested. We're interested in that, having a structured approach to the methods that we may use to help facilitate the uptake of research into routine clinical care into various different contexts. And while I'm also here, just to mention that this will also include de-implementation of interventions. There are probably some practices that you may be aware of that could be considered maybe low or of low value care or of less clinical benefit than another way of doing something. And then we might want to be thinking about de-implementation. So in implementation science, I've mentioned in that previous slide that we like to be thinking about a structured approach to be able to understand why something is happening the way it's happening, or how we might want to be designing whatever it is that we want to be doing. So we tend to, there are a lot of theories, models, and frameworks that are available. And these are important for us to use, because if we don't use them, then we can end up, our implementation efforts can be quite inefficient. The use of theories, models, and frameworks helps us build on the knowledge that is already there. There's no point in us reinventing the wheel and thinking we're the first person who's ever done this. We need to have a look and see what's already around, what evidence can we use, and draw on that, and to improve the efficiency with what it is that we're doing, the research that we're carrying out. It also helps us understand why an implementation activity might be successful, or maybe why an implementation strategy has failed. And we need to understand that so that we can then adapt what it is that we're doing and maybe try a different approach or revise the approach that we've been using. And finally, the use of theories, models, and frameworks really helps us move more towards that sort of scientific end of things. It helps us move away from our sort of gut feeling as to what we think is the right thing to be doing, those sort of implicit ideas that we may have, and can help us generate structured knowledge that we can then use to replicate and grow the knowledge that we have about implementing practice. So when might you want to consider using implementation research? Well, there's lots and lots of different situations. And of course, I would say, you should always be thinking about this. But to break it down into a couple of different scenarios, one is where you may have an intervention that's under development. So you might have a new idea, you might have a new practice, you've generated some evidence around it, and you want to be thinking about how are you going to get it into clinical practice. The second one is around slow uptake. So we've got the evidence for a particular practice, but it's kind of taken a long time to get it into practice. And we might want to investigate why that might be and what strategies could be put in place to enable that. The third one might be around sort of unwarranted variation. There may be some variation in practice, and that might be because you've adapted a practice for different communities and different populations. But if we've got unwarranted variation, then we might want to go in and have a look at why have we got unwanted variation and what is it that we might want to be doing about it. Some more here that are around not keeping up with the evidence base. So we might have a unit or a practice that are not keeping up with evidence as it's changing, which really kind of feeds into this second one here around there can be a shift in the ethos of care. The way we're thinking about delivering care can change. And so if that's happening, then that might be an area that we might want to come in and go, actually, well, should we have a look at this and see what needs to be done? And then the final one, low value care. I've kind of alluded to that in the Blackboard slide and the first slide that talked about research waste and low value care. If we have a practice that has been shown that not to be clinically effective or is considered a low value care, then we might want to be thinking about de-implementation at this point. So what kind of lens do we want to be thinking about when we're thinking about implementation science in rural health? And I sort of mulled on this one for quite a long time, as you can imagine, thinking about coming to talk with you chaps today. Really, it all boils down to is, well, what is your implementation question? What is it that you want to get to the bottom of and find out about? And we can divide this into all sorts of different ways, but I've given sort of two implementation questions that you might have. One would be around equity of access, And the second one will be around, you might have just a local implementation challenge that you want to be considering, and how do you want to think about that? So I thought we could have a quick chat about these two areas to start with. So equity and implementation, this is an implementation equity framework that some of you may have come across, that Woodard and colleagues came up with, and really combines two frameworks and brings two frameworks together. One's a health equity framework, and the other one is an implementation science framework, the Paris framework that some of you may well have heard about. And what this framework does is it kind of provides you with the factors that you might want to be considering if you want to be achieving equity in your implementation practice, or in a practice that you're delivering. At the heart of it is the clinical encounter. So this may be where you want to be starting about what is the clinical encounter that we might be considering. We can't lump everything into the same bucket. Not all rural health is just going to fit into one nice tidy bucket. There will be a whole range of different things that we want to be thinking about that happen within the context of rural health. So we might want to start off with that clinical encounter and consider the patients and also the providers. Who is it who's receiving care? Who is it who's providing the care? And so be analysing our implementation, considering these two communities. There may be other recipients involved. It may be other stakeholders. That could be carers. It could be far wider. You might be going further out and thinking about, well, organisational factors that influence into this sort of other recipients. And we, of course, need to be thinking about what are the characteristics about the particular model of care that we're looking at implementing. All of this sits into this wider context of the outer and inner setting at various different levels. So we can have our local level, and that could be a local level like a team level, or it might be a unit level. And then we've got an organisational level that we might want to be thinking about, well, what's the health board or trust that we're working within? And again, this then sits in within this wider remit of sort of socio-political forces. What is it that's driving healthcare at the moment? Economies, and what are the physical structures that we're working within? And so all of these factors need to be considered along with facilitation, and facilitation is something that's very much come out of the Paris framework and very much feeds into the leadership that comes into play with this. And it's these factors that are all going to come together, according to Woodard and colleagues, that are going to lead to a successful implementation and to see some changes in health equity. So I said right at the beginning, we might want to identify the clinical encounter, and we might want to be thinking about the recipients from a patient and a provider level. So I thought it might be interesting for us to it might be interesting for me to just share sort of one example of some work that I've done with Australian Genomics at that very, very early point, where we knew that we wanted to look at prioritize, or who do we need to be prioritizing, the what and the who, thinking very much about clinical genomics. There was a lot of anecdotal evidence about there being various unmet needs for genomics across Australia. So we were very interested in actually sort of getting in and going, well, actually, rather than there being sort of people saying this, that, and the other, how do we find out what's the nub of it, and what are the consistent messages that are coming through? So for this very, very early study that we did, we spoke with the clinical leads across the various labs and units in genetics and genomics across Australia, and undertook a series of interviews to identify their perceptions on unmet need. And they came out with, or as a result of this, we came out with this list of rural and remote communities, culturally and linguistically diverse populations, Indigenous populations, and people with specific clinical conditions. And for various reasons, we selected that actually we were very interested in digging down more into rural and remote communities and identifying the detail of what's happening for genomics in the field of genomics with rural and remote communities. And at the moment, we've got a geographical information systems study that's going on that's looking at where genomic tests are being, or where people are living who are having genomic tests. And we're going to be comparing that to the population density that we expect to see. So it's not about the number of tests that might be done in a rural area. It's actually, is that representative of the population that lives in that area? So it's a current study that we've got ongoing, and maybe one day I'll be able to come back and let you hear how we're doing with that. The second area that I thought would be that when we say, you know, sort of what sort of lens should we be using, can be about thinking, well, what is our local implementation challenge? It's kind of almost irrelevant whether we're in a rural or a metro community. There's a specific problem in front of us that, or a challenge in front of us that we want to be having a look at. And so there are numerous frameworks in implementation science. So for one reason, that's really good, because it means there's usually something that we might want to, that could be applicable for the situation that we're looking at. On the flip side of that, it can also be quite, whoa, just how many frameworks and how do I get into this? So this is quite, I think this is quite a nice paper that Nielsen wrote a few years ago now, 2015, quite a few years ago, of subdividing the frameworks that you come across within implementation science. And if we look at this yellow line here, I think that's the best one for us to home into. And so some of the frameworks that you'll come across in implementation science are really good for providing you that describing and guiding that sort of process of the implementation research. And so that implementation equity framework that I just showed you a slide or two ago, that fits beautifully into that column there, because that's very much about describing what it is, who may be all the people that we want to be engaging, and what are all the factors that we might want to be looking at. It doesn't really tell us how to do it, but it kind of gives us an idea of how we might want to structure our research. The second one here is much more about the understanding of what is it that impacts the implementation process and outcomes that we might see in our implementation research. And I've got one of these in an example in a slide or two's time, so we'll talk about that in a second. And then the final one here is the final yellow box here is about evaluating implementation. We always need to evaluate our efforts, whether it's an implementation research, but we need to be evaluating what it is that we're doing so that we can find out, you know, sort of what value has it had, has it worked, what's worked and what hasn't worked about it. So the example I just had in the sort of back of my mind that to be able to share with you today, this is about a rapid genomic testing and a study that's been led by professors, and it's a start down here in the Royal Children's Hospital where I am now. So back in 2018, genomic testing would take 6 months or so to get a result back. So you do a genomic test on somebody, and then you sort of wait for 6 months to find out whether it had any clinical significance. And for some people, that's absolutely fine. But when we're talking about acutely ill children who are on PICU and NICU, 6 months is clearly of no use to anybody. So Professor Stark was very interested to see whether we could actually speed that up so it could become a clinically useful test for this population. So this is the paper that we wrote. I mean, it's a bit blurry, so I'm not expecting you to read all of this, but just to give you an idea that what we did is we identified the barriers to implementing rapid genomic testing. We identified what the solutions were that were put in place. We used something called the Consolidated Framework for Implementation Research, and I'm going to talk about that just a bit more in a second. And we had a look at, so what kind of effect did doing this have? So this is my excuse here to talk about the Consolidated Framework for Implementation Research. So this is one of those frameworks that I mentioned that was in that middle yellow box that we just had a few slide or so ago. So the Consolidated Framework for Implementation Research has got 5 components to it, and there's got lots of subdivisions within each of these different domains. So we've got the outer setting. So what is that wider, and that might be that socio-political, that might be policy setting, it might be you know, sort of what MSAC numbers are coming through, whatever it might be. Then we've got the inner setting. So that might be more in our immediate vicinity, things that we can have maybe more immediate influence on. We also need to be thinking about that process of implementation, so the nuts and bolts of implementing. And clearly the characteristics of the people who are involved in this kind of work are going to be really core to how an implementation effort goes on. And then, of course, the characteristics of the intervention itself. Can people trial it? Can people test it? Can they adapt it? All sorts of, how complex is it? All sorts of features like that. And if you search Consolidated Framework for Implementation Research, they have a fantastic website that gives you all of these domains, subdomains, and more details about the framework. I thought it might be helpful to just pull one of the barriers out that we had in that sort of snip of the paper. So one of the barriers that we came across was around a delay in referral to clinical genetics. And we kind of we examined that sort of more closely using the Consolidated Framework for Implementation Research, and realized actually there were two different reasons that lay behind this. One was around network and communications, and the second one was about this perception of whether there was any relative advantage to be using rapid genomic testing. So what we did is we implemented a solution of communicating a rapid whole exome sequencing, genomic sequencing, and we communicated for the first for the networks and communications. We communicated about the availability and the process, and more about why and when you should be thinking about referring for a rapid genomic test. And that ended up having the effect of getting some earlier referrals into clinical genetics. But clearly, if we did that same process for the people who are concerned about the relative advantage, is there any point in us referring? Why would we bother? We've got so many other tests. So with the relative advantage, what we did is we promoted the feedback around what impact undertaking genomic testing was having, what were the diagnostic rates, what was the clinical impact. And that helped clinicians to be able to see what impact they were having and whether they would be wanting to sort of partake with this. And that increased the number of referrals into clinical genetics. While I'm on this trial, I'm just popping in one implementation design that's quite a useful one to be thinking about. It's called Hybrid Effectiveness Implementation Research. What we don't always want to do is we're used to having sort of clinical effectiveness research and then waiting before we actually do the implementation research. So clearly we want to have a clinically effective product that we want to be implementing, but we don't necessarily want to wait until it's totally done and dusted before we start thinking about implementation, because we will have lost so much time. So we can think of a hybrid 1, hybrid 2, or hybrid 3 effectiveness implementation trial. The hybrid 1 is where the primary thing that we want to do is identify the effectiveness of the clinical intervention. Absolutely, this is top-notch, the thing that we want to be doing. While we're there, we're going to collect a little bit of implementation data so that if we do move into the next stage, we're ready to rock and roll. Hybrid level 2 is where we've generated that some of that clinical effectiveness data, but we still want to collect more. But actually, we're sort of confident it's going to be moving in the right direction, in which case we want to be balancing out the effectiveness and the implementation research become side by side. And then this hybrid 1.3 is where actually we have so much clinical evidence, it's an absolute no-brainer, we should be doing this. In which case the primary research focuses on the implementation, and we might want to be thinking about scaling up and sustainability. And the second one is about effectiveness. And this is something that we did in the rapid genomic testing that I was just talking about. We started off with a single state and just 2 hospitals and 1 lab. We then moved on to a multi-state trial with 10 hospitals and 2 labs and a reduced turnaround time. With using the Consolidated Framework for Implementation Research, we informed implementation strategies and formed future implementation. There's some papers that came out from that. Okay, so you might remember way back at the beginning, I said I've got one slide that talks about outcomes. And I find this is a really helpful slide to be thinking about when we're planning a research study, where we might, what sort of outcomes do we want to be talking about? So we're very used to putting something in place and to be thinking about the health outcomes. Clearly, we want to see an improvement in patient well-being. And we're also pretty good, getting better these days, at thinking about service outcomes. And you can see sort of a list of service outcomes here. Oh, wrong way, sorry. Then the final outcomes that I've got here are around implementation outcomes. So there's a whole range of implementation outcomes that we might want to think about: acceptability, feasibility, sustainability, fidelity. Now, what I'm not trying to say is that you should look at all of these and all of these and all of these for every research study that you do. But if you're doing an implementation trial, you might want to identify a health outcome, or some health outcomes and some service outcomes, and identify which are the most appropriate implementation outcomes to be considering. Early days, it's often important for us to be looking at the acceptability and the feasibility of a project that we might be putting in place. And there are all sorts of frameworks that we can be thinking about when we're thinking about those particular implementation outcomes. So you may be sitting there thinking, I have got an evidence-based clinical intervention, what should I do? So the first thing that you need to do is to understand the context. I've underlined evidence-based here, and I cannot stress this enough, that we need to know what is the evidence behind whatever it is that we want to be doing, we want to be implementing. How do we know that something is a problem? What information do we have about this problem? Before we get onto this next stage of generating strategies, who are the people that should be involved? Who are our stakeholders? Who are the people who are possibly likely to disagree with us, but actually we still need to talk to them? So there's a lot of groundwork to be done at that stage. Once we've done all of that groundwork, we then want to start thinking about what are the implementation strategies that we might be using. Now, we might be thinking about this from a top-down perspective, or we might be thinking about it from a bottom-up perspective. Two quite different ways of us looking at that, and that's another talk altogether, maybe next year, or maybe something before then, you never know. Once we've identified our strategies, and we may have informed those using theory from our step one, we then want to implement our strategies, and then finally we want to assess and amend. We're very, very good in healthcare, and I speak here with somebody with quite a long clinical background. We're very good at doing this middle bit here. We're not so good at taking the time here, and we're not so good at taking the time at the end. And in our favour, actually, these are the bits that don't tend to get funded. People want to see doing, people want to see product, people want to see output, but actually we need to spend that time at either end, because otherwise we're going to be wasting a huge amount of time. Our other option is to be using something called the Isli-Guyat method. And this stands for, it seemed like a good idea at the time. So if we don't take the time to really understand our context, then we can put a strategy in place that seemed like a good idea at the time, but it could be a non-problem that we're trying to resolve. If we haven't engaged consumers, we haven't reviewed the literature, we haven't spoken to our stakeholders, surveys, interviews, whatever might be the most appropriate thing for your particular project, it could just be, it seemed like a good idea at the time. And this is an example of an Isli-Guyat approach. So this is an all-in-one nail cutting solution, so that you don't have to spend your time going around each of your nails. But the question is this a solution that we actually need? Is there a problem that we want this as a solution for? So over the image there of the Welsh Rugby Union team, really important to stress that implementation is a team sport. This is not something that anybody can do in a dark room on their own. You very, very much need that content expertise to come together with the implementation expertise. Your context expertise may be from your clinicians, it may be from your consumers. Thinking about my work in genomics, it could be from the lab scientists that you're working with, maybe comms people. Who knows who your context expertise is where that's going to come from. And then people like myself around the implementation expertise. How are we going to structure this study? What are the outcomes that we want to be looking at? What are the measures that we're going to do? Do all these things sort of fit together? I can't stress while I'm sort of saying this is, encouraging you to be thinking about implementation research. But much as that image that we had early on around the research continuum, this stage of the research continuum, there is no quick fix. We need to take our time to understand that context before we generate strategies and put them in place, and we need to be evaluating them, and we need to be going sort of, it's never going to be in a straight line. It's always going to be. Implementation research is based on good data science, collaboration, identifying who our stakeholders need to be. Clinical engagement is absolutely key. And not only is it not quick, but we need to fund the activity that the research activity that we want to be doing. So, in conclusion, if we let the evidence that's being generated slowly trickle out, then actually it's our patients who are going to be missing out on that long lag before research comes into practice. And that's, of course, if the research makes it there at all. I would say that if we want to be implementing evidence-based practice, we need to be actively implementing whatever our areas that we're interested in. It's really key for us to be able to identify what our implementation question is. What is it that we want to be, what's the nub of what it is that we want to be looking at? If we try and look at something just too vast, we're never going to be able to investigate that. We need to really identify what it is that we want to be looking at. There's a whole plethora of frameworks that you can be accessing to help inform your practice. And then really, again, to stress that implementation is something that we can't do on our own. We need to be doing it as a group activity, particularly if we're thinking about ultimately scaling up and sustainability, but also those early days around acceptability and feasibility and those sorts of things. If I find something acceptable, it doesn't mean everybody else does. So very much a team effort. So with that, I think I've left plenty of time for questions. Thank you very much for listening. Yeah, happy to take questions now, or these are my contact details.
Thank you very much, Stephanie. We've got some questions. If
Great.
As you said, you'd like to answer them. And probably one of the first ones, or one that had a couple of ticks against it, relates to what's the best way to engage our senior clinicians and the hospital executives in this type of activity, particularly in a rural setting?
Yeah, really, really good question, and really fundamental question. We want to be thinking about our senior clinicians, but it's also how to engage everybody, really. And I think that probably the nub of that's my word for today, nub. The core of that is around identifying what actually is the problem. So not straight away coming in with the solution, but actually really identifying what is the problem and what is the evidence that goes behind that problem. So if I think about that rapid genomic testing example that I sort of gave in the middle there, the problem was really clear for us to be able to articulate that actually we could not help any of these children in this setting because the test was taking too long. And you could identify the number of children that this was going to impact and the potential clinical impact that your having some sort of intervention here would impact. And so by articulating what the actual problem is, I think can really help. Then if you can then articulate what it is that you want to do about it, how is it you want to go about your research activity? And it may be you've got some sort of solution in your mind, and that's great, but you need to go through that process and go, is this the solution that we need to be applying? So it's not, for me, it's not about going with just the problem or just the solution. It's about really being able to articulate what the problem is and why it's important for us to do something about it. If we're talking about it at very much a sort of, that sort of higher kind of strategy type level and organizational level, then I would very much be tying that in with what are the organizational objectives? What are the policy objectives of maybe your local area or state, or is there an Australian policy that we should be delivering to? So how do we tie into what the drivers are for the people that we're talking with? What are their drivers and how do we meet those?
Thank you. So another question, which is probably not unrelated. Do we have a sound understanding of the factors that hamper or enable the uptake of research findings in rural settings?
I would give you a sweeping no, which is a very little help, isn't it? But I would say, and I think, as I was sort of saying halfway through my talk, is that rural health is a vast area. So we're not talking about, it's not a homogenous entity, rural health. Being in a rural setting is about, that's the context and community in which we're working and we're delivering care. And so that's going to impact our participants, our patients, our consumers, and also our providers. So it will depend on what it is that we want to look at as to whether we have a good understanding. So it depends on maybe a particular care intervention that we want to be putting in place, as to whether we might have an understanding for that particular area. So it might be about, for example, antibiotic prescribing. I would have to go to the literature and find out, what do we know about prescribing antibiotics in rural settings? What are the things that enable appropriate prescribing, and what are the things that are sort of getting in the way? Then I would want to go and talk with the stakeholders, and by that it would probably be GPs, other clinicians, probably pharmacists, very much in a rural community, and as well as patients and consumer advocates. So I think that hopefully with that example, I've kind of demonstrated I can't really give a sort of blanket yes or no, because it will really, really depend on what it is that you want to be doing.
Great, thank you. Another question here is probably a tricky one, but
let's give it a go.
How can we address the inequity of funding of health and medical research so that more of the spend is in rural areas? And the fact that you are there based in a metro area and in a very large institute.
Yeah.
Whether or not there's any practical ways that we can perhaps share the funding.
Yeah. Oh, that's a lovely question. I like that question. And again, I probably haven't got one answer for it. I think there are probably a series of answers. One, as you were just saying, sort of people like myself I'm sitting in a huge institute. Sometimes I'm down the road at Peter Mac, which is another huge institute. But that doesn't mean to say that all of the work that gets done is actually only in our local setting. Yeah. So a lot of the work that gets done by people like myself is based far more widely. And so there are people who are interested in engaging in rural health and looking at interventions that may be of benefit. So I think probably one of the key factors that we might need to look at is that whole relationship building. And that, I know it all takes time, and I know that. And it's really hard, particularly hard as we've gone through this pandemic. I've just started a new job sort of down the road with Peter Mac and VCCC, and we're all working online. So building the relationships can be really quite hard. But it's about sort of engaging with different people who could be working in that field, that are doing work that you're interested in, and developing that connection. And then the next step probably on from that is about looking at, well, what are the grant opportunities? What are the different MRFF and MHRC opportunities? Maybe philanthropic funding. So thinking about it very much from a cancer perspective, is there some specific cancer funding that we could be applying for an implementation project? And so having built those relationships, to then be in a good place to be able to submit a bid for funding that would that either the focus is rural health, or actually that rurality comes into play. And so how are we making sure that rural communities are being acknowledged in here? So one example I've got, for example, is we've just completed a program, a big federal project called Mackenzie's Mission, that was looking at implementing free reproductive genetic carrier screening across Australia. And one of the core things in that was making sure, thinking just about the healthcare providers for a minute rather than the patient, was making sure that the healthcare providers were representative in the study were representative of the Australian population. So that wasn't a study that was particularly about rural health, but it was making sure that the rural community was represented as it would be in real life. So and then the third thing, and I promise I will let us go on to another question. The third thing I think is really about, almost coming back to that point I made a minute ago, is about being able to articulate your argument. We can feel really passionately about something, but if we can't articulate our argument either in the way a policymaker or a funder or whatever the criteria are for the funds that we're going for, if we can't articulate our argument in a way that they want to hear it, doesn't matter whether we're talking about urban health, metro health, whatever health, we're not going to get that work through. And that, I think, again, comes back to that building those relationships so that you can have that core of people who can be critical friends and be reviewing whatever it is that you want to be submitting to get your research funded. And sorry, I know I did say I would promise I would finish that last one, but really just that a quick last one, just to say that rejection is kind of part of academic life. So we put a grant in, whether it's a rural health grant or not, and we will need to put it in, we'll need to take on feedback and revise it and look for another avenue. So resilience and perseverance in that mixture as well with all of those things.
Yes, well, that's something that rural health and rural communities have in spades.
Yeah.
And another question here that's come through the Q&A.
Oh, yeah.
How important is engaging with consumers in this type of research, and what has been your experience working with consumers?
Absolutely. Thank you. Thank you, Nicole. That's a fabulous question. I think engaging with consumers is absolutely fundamental. It really depends on the work that you're doing. We need to be realistic as well. Some of the work that I do is very, very clinician centered. And so I might want to engage with consumers and just make sure that sort of the direction I'm going in is sort of on track. But some things are directly impacting on care. And so coming back to our sort of multiple, sort of nail clipper kind of thing, we want to make sure that the implementation research is actually addressing a problem that consumers really want to have addressed. Otherwise, there's loads of things we could work on, aren't there? But actually, if it's not a priority for consumers, then there's probably something else that we might need to be thinking about. So I've just finished a study that was co-designed, co-led with a consumer advocacy group called the Genetic Support Network Victoria. And we ran a study over the first year of the COVID-19 pandemic, a journaling study, the COVID-19 Journals study, to look at the experiences of the genetic undiagnosed and rare disease community. So the consumers were absolutely central to designing and running that study, which then led on to a prioritization exercise, again, co-designed and co-led with my consumer colleagues. So, which is then sort of prioritize where it is that we should be focusing our efforts. So the next step will be to think about, well, how do we go about funding some research to be looking at these particular areas? And again, that's something that will be done in partnership with clinicians. I think what we have to be really careful about is making sure that we don't have token engagement with consumers. I think that can be quite easy to do. Oh, well, we spoke to one person and they thought it was good, so we cracked on with it, kind of thing, and comes back to that sort of that relationship building that needs to be done, so that we're having an ongoing discussion with consumers about priorities and maybe some of the roadblocks that we're experiencing as well in the clinical setting. So yeah, I'm a great advocate for consumer engagement.
Okay, we've got another question there in the Q&A. Along with the focus on doing things collaboratively, do you use any particular co-designed theoretical frameworks with your implementation studies?
Yeah, no, that's a really good question. I don't know if I use specific co-design theoretical frameworks, but the frameworks that I tend to very much come from the implementation science sort of background, which is often why I'm sort of brought into something, because we want to be thinking about how are we going to be implementing something. So, for example, often we might be very interested in how do we change behaviour in a particular setting. And in which case, I might want to think about using some sort of behaviour change type theoretical framework, something like the capability, opportunity and motivation behaviour model, or maybe something like the theoretical domains framework. And so structure some of the work that we're doing in co-design along those sorts of avenues. But there are lots of different approaches that we can be using when we're thinking about co-design. I don't know that I would necessarily use a specific co-design framework, though.
Thank you. And this might be our last question, I think, given the time. So Susan has said, thank you for your presentation. We often see brilliant guidance documents released that help translate the primary literature into practice guidelines, but then struggle to implement those in rural areas. Do you think that the groups releasing the guidelines will ever include implementation science principles to help with that next step?
Yeah, excellent. So oftentimes, I don't remember whether we had that sort of 4-piece sort of how do I go, what do I need to do if I've got an evidence-based practice? And that second one was about sort of generating strategies. And so oftentimes people will generate clinical guidelines, and clinical guidelines, great, they can be really, really helpful. But just as isn't really of any help to sort of man the beast. It doesn't really help us understand the context in which we're hoping to implement those clinical guidelines. It just says that you need to do this, or you need to do this, and you shouldn't do this kind of thing. And so really, if we're, and the reason I'm smiling is I'm on a group, I've been invited onto a group who are developing some clinical guidelines at the moment for a particular condition. And very much by having me on board at this sort of very early stage while they're developing the clinical guidelines, I'm asking all these sorts of questions. So how is this going to look in practice? What's going to happen? How is this going to actually are we going to be able to play this out? What are going to be the barriers, enablers in different situations? Is this realistic for us to be putting this into some clinical guidelines if we've got somebody who has a nurse specialist twice a week turn up, whereas actually, and we're saying that we need somebody going in twice a day to be able to do this. So I would be a strong advocate for there to be an implementation plan that goes along with the development of clinical guidelines. There's a lot of work goes into developing clinical guidelines, which is great, but it only gets us to so far. It doesn't necessarily get us to the changing practice. And we need to identify what it is that we need to put in place to get over any sort of barriers and identify what those enablers are for us to be able to get those guidelines then into practice. But just the guidelines only get us that far.
Okay, well, we could call a halt to the questions there. Thank you, Stephanie. That's been fantastic. And look, it's been wonderful to have your insights today. We really appreciate your contribution to Research Week. I believe we'll be able to take that knowledge and that we've gained today and use it going forward. And also, I hope we can continue to work together for the benefit of rural health. So thank you to everyone who participated today and who sent in their questions. People have come from all over Victoria and New South Wales, which is fantastic. So if we could have a little bit of virtual applause for Stephanie.
Thank you very, very much. And thank you so much for inviting me. An absolute pleasure to be really focusing on rural health for a while.
So thanks again, everyone, for coming along for our Research Week webinar. And thank you again to Stephanie for her expertise and her wonderful presentation. Enjoy the rest of your day and enjoy the rest of Research Week.